Good morning and greetings from India. I am thankful to the International Society of Hypertension for asking me to talk on a topic which is of great interest to all of us. I have no conflicts of interest to declare. So we are talking of social determinants of health, basically cardiovascular health. And these are conditions in which women and men are born, grow, work, live, and die. There are multiple political and social interventions which can shape these conditions so that people can lead a flourishing life. Social determinants also influence proximate risk factors like pollution, tobacco, unhealthy foods, physical activity, and stress. And there is a great interaction between social determinants and other factors which are important in cardiovascular disease, etiology, and pathogenesis. There are political and social issues. WHO also says on commercial issues. They influence the physical environment. They also influence the structural environment, individual behavior, which leads to multiple cardiovascular risk factors that we all know very well. Now, what are these determinants? Now, I have classified them into two groups. One is the macro level factors, which is the community of residents, the social and human development, social isolation, income inequality, access to care and health systems, and politics. Of course, pollution is important. Now, what's the evidence that we have? We have been doing a study known as PURE, Prospective Urban-Rural Epidemiological Study. It began from 10 countries, now it is 26. This is a very early paper that we published, trying to show that what are the differences in cardiovascular outcomes, in major cardiovascular disease, and case fatality. And you see clearly here that both case fatality as well as major cardiovascular disease is much more in lower income and middle income countries in the PURE study as compared to high income countries. Now, this is important because what we showed in the same paper was that the risk factors was much more in the high income countries as compared to the low income countries. So clearly there are other factors. And what are these factors? A subsequent paper that we published on socioeconomic status and cardiovascular outcomes, we classified socioeconomic status based on the educational level across the PURE study countries. And what I want to emphasize is that middle income countries, there were 70% Asian countries, basically China, Iran, Southeast Asian countries. In low income countries, there were 90% Asian countries, basically from South Asia, India, Pakistan, Bangladesh, Nepal. So it is typically representative of mostly Asian countries. And that's important because we are at the, although we are at the International Society of Hypertension conference, but it is being held in Asia. And you see clearly here that across these socioeconomic status groups, the mortality is much more in the people who are low socioeconomic status, like low educational status, mostly in the low-income countries and the middle-income countries. And clearly, the mortality is much less in high-income countries. So what are the factors of importance? One, we also did a small data analysis based on the macro-level factors in these countries. And what you see clearly here is that high-income countries have better human development, they have better socio-demographic index, they have better healthcare quality, they have better healthcare workers index, both for physicians and nurses. So clearly, I think it is the social determinants which are causing differences in the cardiovascular outcomes in these countries. Then there are macro level determinants, and we know all of them very well. There are social factors like income, social class, exclusion, working conditions. And there are also individual factors like employment status, educational status, stress, life events, addictions, tobacco, alcohol, healthy lifestyles, and control of risk factors, affordability of treatments, and adherence. And we'll talk about them. Now, what are the risk factors of importance? Most of the studies in the past have been done in high-income countries and middle-income countries. There are almost no prospective study that has identified cardiovascular risk factors in low-income countries. Now, here comes the PURE study, just published a couple of years ago. What are the risk factors in the overall population in middle-income countries, basically Asia, and low-income countries, basically South Asia? And you see clearly here is that lifestyle factors like pollution, like diet, like education, low grip strength, and physical activity are all important. They're top 10 modifiable risk factors. And clearly, we have multiple social factors that influence cardiovascular risk. We also have more granular data from South Asia, from China, from Latin America within the PURE study. And clearly, again, low education is a very important risk factor, a social determinant. And then you have indoor pollution, tobacco, and diet. The strength of association varies across these three zones in the PURE study, but low education remains an important risk factor. Now, what are the interventions possible? We have created a prevention pyramid of cardiovascular disease. And what you see clearly here is that social determinants are the most important, and they are the bedrock of the prevention policies. They also include healthcare financing, policies for smoking, diet, physical activity modulation, and medical education. Of course, you also have risk factors that we manage in our clinics. One of the important documents of addressing social determinants has been put forward by the United Nations in form of Sustainable Development Goals. We all know that there are 17 goals, but goal number 1, 3, and 4, which is basically talking of poverty, of health, and of education, are the most important goals that we need to achieve. And what are the policy interventions possible? We could have social policies like income guarantee, like right to education, maternal child health care, framework convention of tobacco control, taxation on harmful products and trans fats. And then there are health care policies, which are equally important. State-funded health services, universal primary and secondary health care, health insurance for poor populations, and drug price controls. We did a small study on insurance status in cardiovascular disease in our patients at our hospital, 4,500 patients undergoing angioplasties, almost 50% uninsured. And what we clearly see is that the in-hospital mortality was much more among the uninsured people as compared to the privately insured. The government insured people fell somewhere in between. So clearly, not being insured is also a cardiovascular risk factor. WHO has recently highlighted the social interventions addressing poverty, malnutrition, health coverage, education, gender inequality, development of cities, food systems, and climate change. And what a summary for Asian perspective is, we need better primary health care and universal health coverage. We need sustainable financing for health, community and civil society engagement, focus on health determinants by creation of enabling environment, innovative programming, research development, increasing innovation and access. And of course, professional medical education is an important component. And now patient focus and better health literacy has to be part of any social intervention. What can we do for specific risk factors? I'll just run through all these because they're all well known. Air pollution, you can have population level interventions, you can have household level interventions, government support, transportation reforms, shifting to clean fuels, everything is happening in the world. But what is not well known is the household level interventions. There we need better home design and ventilation and focus on cooking devices. Tobacco, we all know that the risk is big. It kills prematurely. It's the most common cause of premature coronary artery disease in Asian countries, and the stopping works. And then if you employ or implement framework convention on tobacco control efficiently, you can reduce tobacco and you can reduce the secondary cardiovascular events because of tobacco. Physical activity, we all know, is important, but recommendations are all right, but we need to focus on built environment. We need to create adequate sidewalks, cycle lanes, street connectivity, safety, open spaces access, and reduction in motorized vehicles. Food is the important component, and it's very confusing. We don't know what to eat. And the focus so far has been on negatives. That means don't eat this, don't eat that. But now this is shifting, and both the European, American, and the WHO guidelines emphasize more on healthy food, whole grain products, vegetables, fruit, fish, nuts, and certain quantity of fruits and vegetables. And what are the policies by which we can do that? We can do national nutrition policies, we can do workplace and school-based interventions, and there could be family-based interventions also of importance. Don't forget that the risk factors like hypertension, non-HDL cholesterol, and diabetes are also a social construct, and non-adherence, I believe, is a very important cardiovascular risk factors. There could be multiple factors to improve adherence. Could be physician-specific factors, could be patient-specific factors, but ultimately we need to combine all of them. Education of physicians, audits, reminders, and for the patient, social support, education, compliance, simplifying the regimes, and improving health literacy. Of course, technology is important. We recently chose 3 important risk factors for improving cardiovascular outcomes. And I think we need to control location-based disparities by creation of infrastructure. We need to educate our people, not only general education, but also health education. And we need to ensure availability and affordability of medicines to improve adherence. So, my friends, what are the health system implications? We need to improve health bureaucracy, health systems, and there can be physician level changes and the patient level changes. We can learn from Paul Farmer, a famous public health person working in Africa. And what he famously said was, every patient develops depends care. Epidemics are driven by social, economic, and political and colonial forces. There is no reason why people everywhere cannot get the care they need. He thinks that staff, space, stuff, systems, and support are important. But with struggle and effort, it is possible to bend the arc and overcome the failures of imagination. So in conclusion, socioeconomic factors are important across the life course, and we have identified multiple macro level factors. Micro level factors include poor social capital, low education, pollution, tobacco, and all the lifestyle factors, which are important for coronary artery disease. The intervention should focus on national policies, high quality education, universal health care, and also address gender issues, inequality, healthy cities, sustainable food systems, and climate change. And financing is important for universal health care for both primary and secondary prevention. Thank you.